Hey, welcome. My name is Mike Anglesby. I am a professor of surgery at the University of Michigan. The title of my talk is Opioid Epidemic Prevention Interventions. And these are the objectives. First, I want you to understand that prevention is key to combat the opioid epidemic. I think it's important that we leave the session understanding that how physicians prescribe is absolutely critical to any efforts to impact the epidemic, and talk about some effective interventions that I think we can all be part of in the day-to-day care of our patients. So my interest in this stems from my day job. I'm a transplant surgeon, and I do liver transplants. So in the process of being a transplant surgeon, you either put the organ in or you take it out. And a weekend, 5 years ago, I was on donor call. So that means I was traveling around, taking out organs, bringing them back for my partner. And I had 3 donors in a row who had overdosed. And the first one I remember very vividly was a young girl who had had a sports injury, was exposed to opioids, and got hooked on them. Second donor, like 12 hours later, was a same-aged young woman who had had wisdom tooth extraction, opioid exposure, and got stuck on opioids and overdosed. And the third young woman was at a high school graduation party and was experimented with opioids and alcohol and overdosed. And in the process of this kind of 36-hour period, we had a new policy in the state of Michigan where I did these donors, where we had to kind of stand in silence for about 30 seconds before the operation and listen first to a reading from the family, then just show respect through silence to the gift. And you're just kind of stuck there staring at these donors. And this was kind of before the opioid epidemic had been kind of identified, at least to me, and certainly left an impact on me. And it particularly got me interested in the concept of what we call new persistent use. And what this means is that you come in, healthy patient, and you have, I'm a surgeon, so you have surgical care, dental care, something like that, and you leave the journey, so to speak, continuing to take opioids. And the way this happens is, let's say I take out your gallbladder. I give you a bottle of pills, you take all the pills, we fix your problem you came in for with the gallbladder, but if you take enough pills, let's say I give you 50 pills, if you take them around the clock for 4 or 5 days, by day 6, when you don't have any pills anymore, you feel really bad. And really, the only thing that'll probably make you feel better is taking more pills. And I think overprescribing put millions of Americans at risk for what we call new persistent opioid use. And this is some data from some work we've done showing that across the United States, people who were not on opioids before surgery, who had routine surgical care, things like colectomies, thyroidectomies, gallbladder removal, normal stuff, about 6% of people continued to take their opioids after surgery. And as we kind of expanded on this, that really didn't matter what the type of operation was. This was a very common outcome. This is total hip and total knee replacement, hand surgery, spine surgery. And when surgeries are done kind of for pain, like these, hand and spine, the numbers are a little bit higher. Devastating number in adolescents who have routine surgical care. About 5% of these young adults, these adolescents and young adults, become new persistent opioid users. 10% of cancer patients who theoretically have curative resection for cancer. And then women who have bad breast cancer get systemic therapy, reconstruction, and survive their breast cancer. Almost 20% of them are left as new persistent opioid users. And why this is bad is the vast majority of people who move along to kind of true addiction, so go from opioid use, they progress to opioid misuse, and then addiction and potentially overdose. The vast majority of those individuals got their first exposure to the opioids by someone like me, a surgeon or a dentist. So we think that exposure of opioid-naive patients, people who come in for routine surgical, dental, emergency care, that first exposure to opioids is a really vulnerable time for many of our patients, and we have to be very careful about how we prescribe so that we don't kind of really affect these people's lives long term. And so why does this happen? As a kid, I have a bunch of kids, and we go and they have an ear infection. We go to the pediatrician. They get a bottle of antibiotic, and it's dogmatic. Must take it. Finish it till the end. And it goes on for 5 or 7 days. I think many people, if we give them a big bottle of pills, they take all of those pills. And the data is pretty clear that how much stuff you have in front of you is kind of how much you consume. So whether it be food at a buffet, or there's some really interesting kind of social psychology experiments on kind of how much popcorn people eat at a movie theater. It doesn't really matter how it tastes. It could taste horrible, taste great. The bigger the bin, the more you eat. The same is true for pills. If you give patients a lot of pills, they take them. And if you give them a bottle of 50 pills and they take them all, it really could affect their life for the rest, for a long time, if not forever. And the vast majority of Americans who are given pills have a ton of leftover pills. So almost two-thirds to three-quarters of the pills that we give. So think about it, if you ever had an operation or if you've ever been involved in the care of a patient who had an operation, most of the pills that people like me gave them were never used, and they're in our communities. And one of my partners gave a talk at a high school right down the street from where I am right now, and asked the high school students how many of you can get your hands on opioids in the next hour, and the majority raised their hand. These pills are within our communities, and they really fuel the opioid epidemic. So kind of right-sizing prescribing, giving patients the pain care they need, but not giving them more opioid pills than they need is absolutely critical for the safety of our communities and for the safety of our patients. So this data shows kind of where do prescription opioids kind of come from for people who abuse them. And as you can see, the vast majority in the blue thing are obtained from a friend or family member or from a physician. It's relatively rare people get these pills from a drug dealer, so to speak. It's only 5%, 4%. So these pills in our communities, and we as physicians are really culpable for a lot of these excess pills. And all of us as caregivers need to be part of the solution to to fix this problem. So this is the conceptual framework that we think is critical to really protect our patients from new chronic opioid use, because that really fuels the opioid epidemic and the real devastating complications of chronic opioid use, which is essentially addiction and overdose. So patients not on opioids getting surgical care, giving them the best possible pain care and trying to find ways to give them the best pain care where they get just the amount of pain medicine they need. So to do that, we have been working for many years in the state of Michigan to come up with what we call opioid prescribing recommendations. And these are evidence-driven prescribing amounts for common surgical procedures. And every 6 months or so, we update them. We understand, we know how many pills people are given. We know how many they take, and we try to right-size the numbers. So just as a point of reference, laparoscopic cholecystectomy, which is up on here, the number is 10 pills. Just about 2 years ago at my own institution, we were given about 45 pills. So these numbers are many-fold less. And when we give fewer pills, people take fewer pills, and they're much less at risk of becoming chronic opioid users and moving on. Addiction. And as you can just kind of review these things, if you're involved in the care of any of these types of patients, you can kind of see what at least in the state of Michigan, what we recommend. So for example, for routine dental extractions, it's a particularly vulnerable population. Our data shows that opioid exposure to this population really can have devastating effects. We suggest patients are given no opioids. This represents at least a 50% reduction of recent kind of practice. Another key part of best care is educating, and more than even educating, facilitating disposal of leftover opioids. So hopefully patients won't have that many leftover opioids. but if they do, then we have to help them get rid of them. So they can bring them back to various distribution or collection sites. But one thing we've done, we did a little randomized trial at our institution, is we gave patients kind of disposal bags, and we increased disposal from 28 to 57%. These are little charcoal bags that cost $2 or $3. And when they get the prescription, they can use the bag to dispose of the leftover opioids and keep them out of their homes where they're certainly at risk. And then we have kind of implemented various other kind of pain optimization pathways. You can't to dispose of the disposal bags, and we increased disposal from 28 to 57%. These are little charcoal bags that cost $2 or $3. And when they get the prescription, they can use the bag to dispose of the leftover opioids and keep them out of their homes where they're certainly at risk. And then we have kind of implemented various other kind of pain optimization pathways. You can't just not give pain medicine to patients who have surgery. You must give them best care. And that's why, policies are an important part of combating the opioid epidemic. But I think caregivers are really the ones who are going to fix this problem. And because we're the ones who do the education and the care planning for our patients. And we put them on a pathway where they have expectations of what the pain's going to be, and we make sure they get excellent pain care, and we don't put them at risk of really the devastating complications of these pills. And equally important to all of this is, how do we care for patients who do continue to take opioids after any kind of acute event, like a broken bone, a trauma, or a big operation, or even for dental care. Historically, they would kind of go from the surgeon back to their best care, primary care providers, and the nurses and clinicians that would do the care. They didn't know. They said, well, they continue to have pain after they had whatever, their spine fixed, maybe. Do I need to continue giving them opioids? And I think the primary care providers are really caught in the middle of this. The surgeons would stop prescribing. They would not kind of be part of the care plan around the patient's persistent pain after surgery. And this transition to care is really unwieldy. This is what the ideal process looks like, where we essentially set the patient up to win so they have appropriate expectations. We're deeply committed to everyone along the care pathway, and we'll give them the best pain care possible. And if they have persistent pain after surgery, they have access to the care they need for best pain care. This is hard to do. There are care coordination, as anyone knows, is always a challenge, and there's not always an adequate number of kind of physicians to kind of fill this void. But this is what kind of ideal transitions to care look like within a practice. And then once again, I have to restate that this is just not about not writing for opioids, and there's certainly some evidence that patients who are chronic on opioids and then doctors were not giving them anymore can have had problems with withdrawal and potentially even moving on from kind of prescription opioids to kind of street drugs, and they're certainly at higher risk if that happens. So this is about best pain care from introduction of the patient into the healthcare system. Kind of prescription opioids to kind of street drugs, and they're certainly at higher risk if that happens. So this is about best pain care from introduction of the patient into the healthcare system to caring deeply for the patient throughout their entire journey. So I think these are the key patient care issues that I've learned in the last 4 or 5 years I've been working on this problem. I think it's absolutely critical that we make it clear to every patient that we care for them. We're here to care. All of us in the business are about caring for the patients, and we care about you and we care about your pain. I think it's critical to tell patients what the expectations and norms are, and those need to be informed. So those need to be evidence-based, and those have changed over time. We didn't used to give a bunch of opioids after surgery. Then we started giving too many, and we have to reset those norms. So set the expectations. I'm taking out your gallbladder. I care about your pain. I expect you to have pain. Surgery hurts. The average patient doesn't take any opioid pills after this. They take Tylenol. They take ibuprofen around the clock. but here are 4 pills in case you need them for the first night or after surgery, and we will call you tomorrow and make sure that you are comfortable. I think that's what we say to our patients now. It's a big change from the recent past, but those expectations are key. For all leftover pills, we should facilitate opportunities for those to be disposed. Any patient who calls and is in pain, they need to be seen by a clinician. These are the at-risk patients who continue to have pain after any event, and they're the ones at high risk for persistent use and then moving on to worse problems like addiction. So if someone calls me now and needs a refill, I'll say, absolutely, I want to care for your pain. Come in, please, and see me. And we will make sure that they get the best possible care. And the transitions of care, which are hard. Any transition of care in healthcare is always unwieldy, but it's absolutely critical that these patients who go through, I had a patient I did a liver transplant on not that long ago and really struggled with persistent kind of whole body pain after the liver transplant, which they had before. And we have worked really hard to get them set up to great care locally so that they can really flourish after such a big event as a liver transplant. And I think that's critical. It's a lot of hard work, though. I think as a final important point, it's absolutely critical that everyone in the care team is saying the same thing to our patients about how much we care about their pain and what our plan is to care for their pain. I think if we do that and we partner with our patients, we can't go wrong. Thank you very much for your time.